morning, distinguished guests, Dr. Champika Wickramasinghe, Director, Non-Communicable Diseases Directorate, Ministry of Health, Sri Lanka, Dr. Krishanta Jayasekara, the President of Sri Lanka College of Internal Medicine, Professor Neil Poulter, our esteemed speaker for the day, Professor Chamila Methananda, Chairperson, Non-Communicable Diseases Expert Committee, and all our valued participants joining us both physically and virtually. It is my pleasure to warmly welcome you all to the World Hypertension Day update on the management of hypertension 2025, organized by the Sri Lanka College of Internal Medicine in collaboration with the Non-Communicable Diseases Directorate, Ministry of Health, Sri Lanka. To formally commence today's proceedings, may I now invite Dr. Krishanta Jayasekara, President, Sri Lanka College of Internal Medicine, to deliver the welcome address. Over to you, sir.
Good morning, distinguished guests, council members, members of the Sri Lanka College of Internal Medicine, virtual and physical participants who are joining this hypertension symposium. It's my great pleasure to welcome you all for this webinar today on hypertension. It's actually held to commemorate the World Hypertension Day, a day that reminds us of the critical importance of raising awareness, improving detection, and enhancing the control of high blood pressure across the globe. As we gather here to explore new insights and share strategies in the fight against hypertension, it is a tremendous honor as the President of Sri Lanka College of Internal Medicine for 2025 to welcome one of the most respected figures in global cardiovascular health, Professor Neil Poulter. Professor Poulter is a world-renowned authority in hypertension and cardiovascular disease prevention with a distinguished career that spans decades. He has contributed immensely to clinical research, public health, and international efforts to reduce the burden of hypertension. As a past president of the International Society of Hypertension and a founding member of the World Hypertension League, his leadership continues to inspire and guide our global efforts. We are truly privileged, sir, to have you here with us today as our guest speaker, and we look forward to hearing your valuable insights on the global state of hypertension control and the way forward. I would also like to welcome Dr. Champika Wickramasinghe, Director NCD, Ministry of Health, for endorsing and facilitating this important symposium. My sincere appreciation will extend to Professor Chamila Methananda, Chairperson of NCD Expert Committee of SLSIM. Without your unwavering dedication, meticulous organization, and passionate commitment to the cause, today's event simply would not have been a success. Chamila, thank you deeply for your timeless work and leadership. So, ladies and gentlemen, let us use the knowledge and inspiration gained today to strengthen our commitment to the prevention and early detection and also effective management of hypertension for healthier individuals, stronger communities, and a better tomorrow. Thank you very much.
Thank you for your warm remarks, sir. Next, it is my privilege to introduce Dr. Champika Wickramasinghe, Director, Non-Communicable Diseases Directorate, Ministry of Health, Sri Lanka, to share her insights on the importance of organizing today's update and its relevance to the national healthcare priorities. Stage is yours, madam.
Good morning. President College of Internal Medicine, Professor Neil Poulter, main speaker for today, Professor Methananda, Dr. Surang, and all the members of the College of Internal Medicine and all the participants present today. It's a great pleasure to take part in this symposium, which is mainly in line with the World Hypertension Day. Hypertension, you know, I need not say, is the cause of many diseases and disabilities in the country. And by controlling hypertension alone, we can actually reduce a lot of healthcare costs. So, Sri Lanka, as well as globally, there is a lot of attention on controlling hypertension using efficient and effective strategies. One of the strategies used is use of guidelines and protocols for the management of hypertension. When we use a guideline, then mainly when we use a protocol, there is uniformity in our management, and also it is easy for us to estimate the requirement in drugs and other items. One of the main problems we face in our country is, you know, we have a free health system and very little attention is given on the cost of the management of patients. So we prescribe any drug for any patient at any time, and you know, we don't care much about the cost of the drugs and also about the complications and all. So it's really high time, and I'm very grateful to the College of Internal Medicine for participating with us in organizing the guidelines for management of diabetes. We did not only hypertension, diabetes, and other disease guidelines also we have produced, and in line with the WHO protocol for hypertension, we have developed our customized hypertension protocol, and we are practicing it since 2023. At the beginning, our control rate was around 40%, but now we have reached more than 60%, and I think the global target is to reach 50% of control rate for patients having hypertension. So we are doing very well, and I'm really grateful for the college for their contribution. They came for all the training programs and, you know, participating in addressing the problems, in updating the protocols and guidelines. So I'm very thankful for the college for their contribution in controlling the hypertension of this country. And also, I'm very happy to be present when Professor Neil Poulter, who is an eminent figure in hypertension control globally, is speaking to us today at this symposium. It's an honor to have you here, sir. Thank you very much for your participation, and I am sure our medical officers will be greatly benefited by your lecture. Thank you very much.
Thank you, Madam. Next, it is my pleasure to invite Professor Chamila Methananda, Chairperson, NCD Expert Committee, to present an overview on the current blood pressure management guidelines, and to have the honor of introducing our distinguished speaker for the day, Professor Neil Poulter. Over to you, Madam.
Thank you. Good morning. First of all, I would like to welcome all the physical and virtual audience for joining this hypertension update. And I would like to thank Sri Lanka College of Internal Medicine and the Ministry of Health for understanding the importance of management of hypertension and supporting in numerous ways. And I would like to thank Professor Neil Poulter for gracing this occasion. Thank you very much. So my task today is to give you an overview of the national protocol of blood pressure management, and then after that I'm going to hand over to Professor Poulter. He'll be talking on the other aspects of the important aspects of blood pressure management. So to start with, we all know hypertension is a global problem, right? So 1 in 3 adults all over the world do have high blood pressure. And if we take about the risk factors, this is the single most important risk factor for cardiovascular diseases. If we can bring down blood pressure in a hypertensive patient by systolic blood pressure by 10 or diastolic blood pressure by 5, it can help us to reduce heart failure by about 40% and strokes by 35% and coronary events by 20%. And if you take the all-cause mortality by about 10 to 15%. So that's a great achievement. Now, because the world knows this, like, there are a lot of blood pressure guidelines developed all over the world, like in the American guidelines, the European, and there is a WHO guideline, several guidelines, and they get updated every year. But the problem is, despite all these efforts, the blood pressure control worldwide is suboptimal. If you take, like, it's like the whole world, it's only 1 in 5 who has controlled blood pressure. So it varies with the country, but so that's why, as Dr. Champika said, the WHO's goal is to make it get it up to 50% control. And then looking at the reasons why we can't control blood pressure in patients, one important reason that we found was, even though there are enough guidelines, there is poor implementation of guidelines in the real world clinical practice. So that's one major problem. Yes, there are other problems, like the patients also need to be compliant and lifestyle modification need be done, but this is one aspect that we can, as doctors, we can intervene at. Therefore, the Ministry of Health Sri Lanka, the NCD Directorate, they have launched a new blood pressure control program, which includes 2 things. One is protocol-based blood pressure management. Here what we use is the simple protocol. The name is simple, which is in collaboration with the WHO, and this is a protocol that has been is being used in about 100 countries all over the world with the resolve to save lives blood pressure control program. And the second thing is, we have digital app-based patient follow-up system we have started. This started slowly started in 2023, and now we have the aim is to roll it out all over the country. Now the protocol is mainly based on it's more or less the same with the ESC 2023 guideline, and it's the same thing that is there in our guideline. Now, this is just to show the app, like the digital-based follow-up. This is the simple app that we use. So we have started this in primary healthcare, secondary and tertiary healthcare, several centers, not in all the stations. So where we register patients on this app so that it's easy for us to follow up patients. Now, this is the simple protocol that we are using in the blood pressure management. I will go into this in detail in next slides. Now, blood pressure management, we know there are 2 main aspects, non-pharmacological management and pharmacological management. So we diagnose hypertension with a blood pressure more than 140/90. Of his blood pressure, what we check in the clinic. But the latest 2024 guideline of the ESC they have developed another blood pressure category, named another blood pressure category called elevated blood pressure. That's between 120 to 139 systolic blood pressure and 70 to 89 diastolic blood pressure. For diagnosis, it is very important that we measure the blood pressure correctly. So that is one aim of the blood pressure control in the World Hypertension Day theme this year, measure blood pressure correctly. There are several things that we need to adhere to when we measure blood pressure, but I'm not going to go into detail with the time, but you can look it up. This is directly taken from the ESC 2024 guideline, the picture. Okay. Now, the second important thing is non-pharmacological management. This is again from ESC 2024. So it has got, like you all know what non-pharmacological measures that we need to adhere to. But just to recapitulate, the most important thing I think I have to get into the public in Sri Lanka is to cut down on salt intake, sodium chloride. So we have to cut down salt intake less than 5 grams per day, right? Increasing potassium is good, so that's why we encourage eating fruits and increasing fruits and vegetables like the banana, avocado, spinach, like vegetables and fruits. They do have a lot of potassium, and we have to maintain the correct BMI. Right? Exercise is very important. Either moderate exercise 150 minutes per week or vigorous exercise 75 minutes per week. And in addition to that, resistant training with isometric exercises is important at least 3 times a day. We have to stop smoking. Alcohol, we have to cut down. Moderation is what is recommended. So stopping alcohol or cutting down would be the best. Now, this is the main thing I'm going to talk about today. So the pharmacological management of blood pressure, the protocol-based management. Right. So once we diagnose somebody is having hypertension, established hypertension, we start them on lifestyle modification. Right. And then whether to start them on antihypertensives immediately or later on depends on their blood pressure. In our protocol, there are 2 blood pressure grades that we recommend. We have developed. So, like whether the grade 2 is blood pressure more than 160/100. Grade 1 is less, the blood pressure between 140 and 160 or 90 to 100. Now, if somebody has got grade 2 hypertension, blood pressure more than 160/100, they should be immediately started on antihypertensive treatment in addition to continuing non-pharmacological management. Grade 1 hypertension, then that is where we need to re-stratify them. We have to see whether they are at high risk. So if somebody has had a CVD before, a stroke or MI, then they are at high cardiovascular risk. Or we can, if they haven't had any before, we re-stratify them using a re-stratification model. What we use in Sri Lanka is the WHO risk charts. So if the risk is more than 20%, that means they are at high cardiovascular risk. Or if they do have CKD, diabetes, or hypertension-mediated organ damage, they are at high risk. In those patients, we need to start them on antihypertensives immediately. But if all these are negative, so like it's grade 1 hypertension low risk, we can observe them for 3 to 6 months with lifestyle modification and see whether the blood pressure comes under control. If it does not come under control within 3 to 6 months, then that is where you start them on antihypertensives. So this is the next important slide, drug management of hypertension. So now we are going by a protocol so that it's easy. Yes, we have a guideline, but then we have developed a protocol so that you need not like think a lot about what to start. There is a protocol, so any doctor, even in the periphery, can use this same protocol to manage patients on hypertension. Now, once the decision to initiate on drug treatment is made, right? Majority of people, anybody less than 80 years, we go along algorithm 1. That is where we start low dose and dual antihypertensive therapy. This is the guideline all over, so like we also follow the same. This is slightly different to what we have been practicing long time ago, right? So in our setting, what we recommend is, so like the two drugs that in the protocol and what we recommend are A plus C. So A is a ARB or AZ inhibitor. C is a calcium channel blocker, preferably dihydropyridine. Now, in our hospital setting, so what we have is like, and considering all those, what our protocol says to start them on losartan 50 milligram and amlodipine 5 milligram once daily. If their blood pressure is not controlled within 4 to 6 weeks, then the next option is to double up the A and C, so to maximum tolerated dose. So that will be losartan 100 and amlodipine 10. So that's step 2. Step 3 is when blood pressure is still not controlled in 4 to 6 weeks, then a third drug comes into place. The third drug is a diuretic. So what we say is thiazide-like diuretic or thiazide. But then in our hospital setting, what we have is HCT. So we have recommended to use HCT 12.5 to 25. So you can titrate it up to that. If blood pressure is still not controlled, that means resistant hypertension. With the 3 drugs with a diuretic, no control. So we go to step 4. The recommended first line drug is spironolactone. We say you can start from 2.5 to 50 milligrams. This is again slightly different to what we have been practicing. Like we used to give prasosine long ago, but then now this is the recommendation. But if somebody is not able to take spironolactone, if it is contraindicated due to some reason like high potassium also, then you can start amlodipine and can even go into centrally acting drugs. There are other options. A smaller proportion of people will go in the algorithm 2. Those are the people who are above 80 years, who are very frail, or like they have just grade 1 hypertension, 140 less than 160, and they are at very low risk, right? So those people, we start with monotherapy. So again, monotherapy, we start with single drug, half dose. So in the protocol, the recommendation is you start them on amlodipine 5 milligram. That is our recommendation in the protocol. Right? Then you can increase it up to full dose, and if it is not, blood pressure is not coming under control, then it comes to the second stage where you add another drug. The second drug to add is A, so AZ inhibitor or ARB, but in our protocol what we say is losartan, simply because of the availability in the hospitals. Right? And then if it's not getting under control, then it's the same, like you add a diuretic, and if it's resistant hypertension, spironolactone. So we go along the same pathway as the algorithm 1. So majority, you start them on low dose dual antihypertensive. That is the message I want to give. And then so this, we have given what drugs to start on. So you need not think a lot about that, right? It's just to go along the protocol. Then the blood pressure control will be very good, because this is a protocol that is being used in several countries, and this is the latest guideline as well, right? Then few things about the drugs. So if we can use single pill combinations, that is the best, but it's not available in our state sector, but in private sector, like at least we have 2 drug combinations. If we can use that, that is helpful to increase compliance of patients. And then like thiazide-like diuretics, like clothalidone is better than HCT, but like those drugs are not available. So whatever you have is okay to be used. Sorry. And then dihydropyridine calcium channel blockers like amlodipine are preferred over non-dihydropyridine like diltiazem in blood pressure control. And the other important thing is beta blockers can come into any step or can be started as monotherapy if there is an indication. So like if they have heart failure, post-MI or angina, then, or like if they have atrial fibrillation, or in young women who are pregnant or who are planning pregnancy, beta blockers is a good option. Now coming on to our blood pressure targets, in our guideline and the protocol, our target is to bring it down below 140/80 in most of the patients, right? But if in frail elderly, if that cannot be tolerated, then in those patients 140/150 is okay. The latest 2024 ESE guideline, they say to try and target blood pressure to bring it down to 120/129 or diastole to 70/79, because the benefits are better, provided the treatment is well tolerated. And there is another recommendation, we do not actively aim to drop blood pressure below 120/70. So to sum up my talk, right, we diagnose hypertension if blood pressure is more than 140/90, right, equal or more than 140/90, right? And all confirmed patients with hypertension, not even without hypertension, they should be on lifestyle, like, good lifestyle practices will prevent you getting all the NCDs, right? Non-pharmacological management is important. So grade 2 hypertension, we immediately start them on antihypertensive management, medications. Low dose dual antihypertensive, A plus C, is the recommendation to start in most of the patients, unless they are frail elderly or they have just grade 1 hypertension with very low risk. Blood pressure target is less than 140/80, but if we can bring it down further, up to 120/70 is okay if tolerated, but we don't ask to drop it actively below 120/70. So that is all I want to tell you. Like, I wanted to get you the protocol before Prof. Poulter is going into all the details. He's the expert in hypertension. If there are questions, we can take them.
What is the AC receptor? AC inhibitors. Now you have put the AC receptor, right?
Yeah.
If the patient also has any cardiac problem, the AC inhibitors are better than the receptor.
Yes, actually.
You not mention the AC inhibitors at all. Enalapril or
Yeah, so A is AC inhibitor or ARB, right? So both can be used, but in the guideline, we have made the guideline not giving all the medications, because then it is going to confuse all the MOs who are working in the periphery, and so if there is a compelling indication and AC inhibitor like enalapril is better than ARB, then that's all right to use it. But there is, by all means, so in the guidelines says to give HCT, because in the protocol, because that is what is available in the hospital. But if the patient can afford a thiazide-like diuretic, that would be the best. But at least, especially this was developed mainly for the periphery as well, if they can at least go by this guideline, that would be good. So actually we have started this program in 25 secondary and tertiary healthcare institutions, and we have now analyzed data, and we see the blood pressure control is there in 60% of those patients, but only tertiary and secondary and tertiary healthcare. But so that's why, so we see that there is some improvement, rather than, because physician inertia is a problem. So they either because of the workload and seeing a lot of patients, and they are a bit reluctant. They are worried that there will be side effects and the blood pressure will drop a lot. But actually it is proven that the side effects are less, because we are giving small doses of 2 drugs, and the effect is better. So the problem the world is using this protocol. So what the message I want to give to all the peripheral doctors and everybody is like, I mean, this is a well, like a trialed the guideline and the protocol. So like, I mean, starting, like following the protocol will help to get blood pressure under control much better than just haphazardly putting drugs then and there. But if somebody is well controlled on some medicine, there is no reason to change the drugs for according to the protocol. But then, like, I mean, when and where, like, if you have to think about what to add next, go by the protocol. That will be helpful. In the absence of any other questions, I would like to introduce Professor Poulter and hand it over to Professor Poulter to go with his talk. I'm very, like, I'm honored, and I'm very, what should I say? I'm grateful for Prof. Poulter for coming all the way from UK just for our hypertension day program. I'm honored to actually introduce Professor Neil Poulter. He's a fellow of the Academy of Medical Sciences, a prestigious UK designation awarded to individuals for their outstanding contribution to medical sciences. Prof. Poulter is the Professor of Preventive Cardiovascular Medicine, Imperial College London, UK. He's currently the co-director of the International Centre for Circulatory Health, and he's the founding director of the Imperial Clinical Trials Unit. It's a world-famous, well-known clinical trials unit, and he's the founding director of that. He was president of the British Hypertension Society from 2023 to 2025, and was the president of the International Society of Hypertension from 2016 to 2018. He has contributed to several national and international guidelines on hypertension. He has played a senior management role in several international trials, including ASCOT, Advance, Excel, like trials. All our trainees are studying all these trials. And he's the chief investigator of the May Measurement Month. You all know, like, we every year participate in this May Measurement Month blood pressure screening program, and he's the chief investigator of that. And there's no doubt that Prof. Poulter is the best person to talk about hypertension management. And without further ado, I would like to invite Prof. Poulter to the podium to enlighten the physical. And we have actually, we are webcasting this all over the country. So there is a lot of people joining online. So everybody will benefit with your wisdom. Thank you very much.
Distinguished guests, colleagues, friends, Chamila, good morning. I'm absolutely delighted to be here. Thank you very much indeed for inviting me. And I'd like to say a special thank you to Prof. Chamila for all her patience in putting up with me trying to organize this. I'd like to start really by saying that the guidelines you just described seem very pragmatic to me. They seem simple, clear, and pragmatic, and overall I wouldn't quibble with any of the things that you described. A little bit in the detail, we could all debate which drugs, which RAS blocker, for example, and which diuretic, but essentially I think what you outlined is a very sensible set of guidelines. Why are we making such a fuss about blood pressure? Well, it's really because raised blood pressure kills about 11 million people around the world in a year. that's over 30,000 deaths per day are due to raised blood pressure. That's far more than COVID ever caused in a day. And of course, the deaths associated with COVID are going to go away, essentially. They're getting less and less all the time, whereas the deaths due to raised blood pressure are going up all the time. So the 11 million deaths a year that are happening now is going to go up. It's going to go up because the world's population is getting bigger, and on average, people are living longer. So as you know, blood pressure rises with age, and so we're looking at something that kills 11 million now is going to go up. And as you've heard, it's going to take big efforts to bring those numbers down. And it's a pivotal thing that we should be doing. Okay, that's the one, blood pressure thresholds. I said, I'm not going to go into more detail than you did, Jamila, really. More the generic story of what to take as the threshold and targets of treatment, and then a little bit on the management, perhaps a bit more generic to the discussion you gave of your local guidelines. I'd like to think I haven't got a conflict of interest, but I show that for political correctness. But I'm prepared to be investigated later if you'd like to challenge that. All right. What's the practical definition of hypertension? Well, it's that level of blood pressure which has investigation and treatment do more good than harm. How do you know that? Well, it's got to be based on trial evidence before you can satisfy that definition. And that's an old definition. That goes back to 1971, and it still holds true. But the latest American guidelines, some years ago, it's about 2017, came away from what you described, 140/90, which is what most of the world accepts now and again. But they, in their guidelines, came up with this. Stage 1 hypertension was from 130 upwards, 130 to 139 and 80s, and stage 2 was what we all call hypertension now. But they did that. And I would challenge them, if you go back to the definition I gave you of that level of blood pressure, which does more good than harm, we don't have that evidence for 130 and above. The SPRINT trial suggested that some of the people in the SPRINT trial began at 130 and above, but they were already on treatment, the vast majority. So I think this decision, I get the idea that they're just trying to drive it down and the lower the better sort of argument, but I don't think the evidence was right. If you were to use that definition, I don't think that was correct. However, a little bit of history. Pre-1993, when I was at medical school in 1542, that was the definition of hypertension, 160/95. But then in 1993, it was this JNC, the Joint National Committee in America, they introduced 140/90, and then as I said, in 2017, the Americans took it upon themselves to lower the threshold, the definition, to 130/80. I'm glad to say that since then, just about everybody has recovered their senses and gone back to what we described as 140/90. Good decision, that's where we should be. And interestingly, if you look at the threshold, this is from European guidance, that threshold of 140/90, here's the diastolics, here's pretty much holds for whatever situation you've got, pretty much. It's extraordinary. Every set of guideline in the world has got a risk chart, and they say we've got to evaluate the cardiovascular risk, and we do. But in the end, when it comes to the thresholds and the targets that I'll show you, it really doesn't make a hell of a difference in terms of our cut points. Certainly doesn't change the definition. So here you are by age, or maybe in the over 80s, that's where the definition alters a little bit. So this is the office blood pressures, and we'll come back to that a bit. The office blood pressure, the threshold for treatment, it's pretty much 140 everywhere and 90 everywhere, the exception being for those over the age of 80. And I have to say, this has come down a lot since the sprint trial in the over the age of 75. These are often being put along here, sticking with the younger age groups, unless, as Prof. Jamila said, you're frail. I think age is disappearing as a determinant. Frailty, on the other hand, is taking its place. And I think that makes sense. So what about the targets? Well, put simply, there's an increasing focus on the systolic, and the conservative target has been 140/90, but it's coming down closer in most of the guidelines to less than 130/80. The story about focusing on the systolic is what predicts cardiovascular events more, systolic or diastolic. And once you're over the age of 50, and most hypertensives are over the age of 50, then systolic is a better predictor. But in young hypertension, below the age of 50, diastolic predicts cardiovascular events better than systolic. So we've got to be conscious in the younger patients of the diastolic. And at some point, several years ago, somebody wrote an article in The Lancet saying, keep it simple, forget the diastolic, just treat the systolic. That's wrong for the younger population. Okay, what about the targets? And we heard, don't go less than 130. And here's the European guidelines that bring that to the fore, not less than 120. But depending on the age range, it's around 140 or 130, target to 130, then less than 140 to 130, and then over 80, a bit more conservative. But it's pretty much the same sort of story. And if you were to summarize it, I think this is reasonable. So long as the drug treatment's well tolerated, treated systolic values should be targeted to 130 or lower in most patients. So put simply, around the world, threshold 140/90, and this is exactly what we show, target 130/80. That's what we should be trying to do. Now it gets complicated because if you want the population to get to less than 130, you actually have to target 120. If you want 80% of the population to be under 130, you've got to target 120. But let's not get into that. I think another different target would complicate matters, and I'm delighted to see that most guidelines don't raise that issue. But so that's pretty much the story. 140/90, target 130/80. Well, then there's a question, okay, so what do you think about 130 to 139? Is that hypertension? No, it's not. It's abnormal, it's raised. So that's a band where non-pharmacological measures, probably a population-type approach, should be introduced. So how do we lower blood pressure? Taken from the Lancet Commission almost 10 years ago now, using lifestyle intervention. This is an important quote. It's striking that all blood pressure guidelines agree that individual lifestyle modification is the cornerstone of prevention, and it's the first line of treatment. And that's exactly what Professor Miller showed. It's the first line of treatment. And you do that for everybody, straight away, as soon as it's raised. In fact, to sort of take people out of using drugs, you may be able to get away with just using the lifestyle measures. What lifestyle measures are we going to use? Well, here's a list of things that have been shown to lower blood pressure. And I'll just highlight the things. Again, this is repeating what Jamila said. Cut down your salt, increase potassium. Dietary nitrate, foods that are high in dietary nitrates. And that's, beetroot is actually the best example of that. Not boiled beetroot, we'll come back to it. Boiled beetroot, you lose the nitrates, no good. Green leafy vegetables, physical activity and improved fitness and weight loss. These are four sort of low-hanging fruits. As mentioned earlier about tobacco cessation. It's an interesting phenomenon when you stop people smoking, or when they stop, they tend to put on weight, and their blood pressures tend to go up. So stopping smoking isn't great in terms of lowering blood pressure. There's a belief that stopping smoking lowers blood pressure, but it probably doesn't. Smokers, don't tell the tobacco industry this, but smokers tend to have lower blood pressures than non-smokers. That's because they're thin, and a lot of them are dying of respiratory diseases and lots of other things. So, nevertheless, it's a wonderful thing to do, is to stop smoking. We should be doing that. But they're the four main simple low-hanging fruit that we should be focusing on. Getting the salt in our diet down, increasing dietary nitrate foods, increasing activity, and losing weight. We'll come back a little bit to that. Okay, here's some examples of what this is all about. The effect of salt substitution. Big trial, 21,000 people 60 and above, or those who'd had a stroke, and they just were randomized to get a low salt product, which is a potassium-enriched salt, 25% potassium chloride, 75% sodium chloride, versus their usual salt, which was 100% sodium chloride. And these are the benefits. Stroke, cardiovascular death, and major adverse cardiovascular events. Highly significant benefits. The blood pressure difference is only 3 or 4 millimeters systolic, but these are the sort of size of the effects just by changing the salt. It's quite difficult to stop people eating salt. If you say don't add salt, they think you're slightly strange. But if you say, well, you can use salt in your cooking, but use low salt. And that's what I do with my patients, really based on this trial. And this is a simple thing to do. This product is cheap, and it should be introduced at the population level and in our patients. Right, dietary nitrate. Most people haven't heard anything about dietary nitrate, and yet these are old. This is 2015 that this trial was published, and this was giving patients 250 mils of beetroot juice, a product called Beet It, and the active component is nitrate. And they got their Beet It juice with the nitrate taken out, placebo, and then they got the beetroot juice with the nitrate. And this is the benefit that you saw from taking 250 mils of beetroot juice. 8 millimeters systolic. That's as good as adding in a drug in most circumstances. Everything goes pink, the pee, the poo, everything goes pink, but as long as the patient doesn't worry about it, their systolic will be down by 8 millimeters on average. That's worth having. And the other thing available with this product, Beet It, is that they do a shot. If you can't, like my wife, tolerate it, she won't mind me telling you she's hypertensive, and I gave her the Beet It juice, and she said, I'm not drinking that. Tastes terrible. So they have a shot, a 75 ml shot, which got the same amount of nitrate in it, so you can just put that back. In fact, I contacted the guy who owns this company, Beet It, and I said to him, there's a problem with your product. And he said, what's that? And I said, well, it tastes horrible. At least half the patients think it's horrible. And he said, well, I agree, it's an acquired taste. And then he said, and I haven't acquired it. This is the owner of the company. So he said, but I have high blood pressure, so every morning I have a shot, I mix it with freshly squeezed orange juice, and I take it. And I don't need tablets as a result of taking his own product. So this works. It's worth, if we can get hold of beetroot juice, surely this can be produced. I say again to the patients, they often want to make their own beetroot juice. That's okay, but don't take it from boiled. If the beetroot's boiled, it won't work. Now, let's just come back to one of the other things we mentioned, and that's weight loss. This is the association in just over 1 million people. You heard about May Measurement Month, and I'd like to thank everybody who's been involved with MMM in the past. In the year 2000, we screened over 2017, we screened over 1.2 million people. And this is the simple association of systolic in red and diastolic in blue, with 4 grades of body weight, starting with underweight as the reference, and you see that. There is nothing in the massive database, now over 7 million people in Main Measurement Month, are strongly associated with blood pressure as body weight. And we've got a problem worldwide. There are now more young people who are overweight than there are people who are starving. When I was at medical school, we learnt about marasmus and kwashiorkor. Nobody taught you about obesity, and it's a bigger problem. So we must get a grip with that, and I don't believe personally that taking injections once a week is the way around it. It's about to happen in UK big time. Huge sway of people are taking this off the internet, and it's going to come in through the NHS. I don't think that's the right thing to do, even though they are undoubtedly massively effective, and it seems to me that semaglutide is a wonder drug, but there you go. That is a real problem. And you hear people talk about the genetics of obesity. That takes my breath away. It's about what you put in your mouth. And we need to do something about it. This slightly cynical cartoon tells a story too. What are you going to be when you grow up? Diabetic is the answer. Fat babies make fat adults in general. And we feed them. And this is a frightening combination, high blood pressure and diabetes. You don't want that. So we have to make an effort to make inroads into obesity. Okay, enough on non-pharmacological measures. What have the recent guidelines said? Well, along with yours, all the guidelines here in Africa, Europe, ISH, WHO, even WHO are very conservative about some of these things. Have said we should probably start with 2 drug classes, as Chamila described. And ideally as a single pill combination, if you can get it like that, because the fewer tablets, the more likely the patient is to take them. What tablets should we take? And I just would recommend to you, this is from the 2020 ISH guidelines. What are the ideal drug characteristics? This table, I think, is excellent, and I think you should always think about this when you're making a decision about what tablets we should take in your context. Treatment should be evidence-based in relation to morbidity and mortality prevention. They're the drugs we should be using, if we can. Drugs that have been shown to produce cardiovascular endpoints. Ideally, you want once daily regimen which gives 24-hour blood pressure control. We shouldn't be giving BD regimens and TDS if possible. Costs affect that. I know it was mentioned earlier, enalapril. Enalapril does not last 24 hours a day, so you have to give it twice a day. If you give it twice a day, the patients won't take it as much. We want, if you're going to use an ACE inhibitor, you want long-acting ACE inhibitors, which the best example is probably perindopril. Treatment should be affordable or cost-effective relative to other agents, and that's very site-specific, isn't it, around the world. This is a real problem in many parts of the world, that the patients cannot afford the drugs they are given. The treatments have got to be well tolerated. If they're not well tolerated, people won't take them. And then there should be evidence of benefits of the use of the medication in the populations in which they are to be applied. Well, you're unlikely to get a randomized trial of morbidity mortality in Sri Lanka on its own, but there are some evidence coming through, and I'll show you an example. So, this is a trial called Topspin, and this is the background to it. Most guidelines, the American ones, the European ones, international ones, recommend the use of 2 antihypertensive agents as initial therapy, ideally as single pill combinations. We're all agreed to that. But there is no randomized evidence to inform the initial combination of hypertension in patients of South Asian origin. This is a quarter of the world's population. There is no evidence of what the best drugs. You've got it for white patients, and you've got a little bit for African patients too, which is the Creole trial, which we did previously in sub-Saharan Africa. So the Topspin trial was set up, and the idea of Topspin Let me just go back. The objectives of TopSpin were to compare the efficacy of a calcium channel blocker, dihydropyridine, plus an ACE inhibitor, dihydropyridine plus thiazide-like, or perindopril plus indapamide, so ACE plus indapamide. 3 of the commonest combinations recommended in the guidelines. So it's using the British thing, A is for ACE, B beta blocker, C calcium channel blocker, D diuretics. So it's C plus A, C plus D, or A plus D. We didn't have enough money to do a morbidity mortality trial, so we just did 24-hour ambulatory systolic blood pressure at 6 months in patients with uncontrolled blood pressure, and they were randomized to one of these 3 combinations. This is the design. It's a great name, I'm sure you'll agree. Multi-center randomized, 35 sites in India. 3 arms, parallel superiority trial. So we had almost 2,000 Indian men or women between the age 30 to 80. And their sitting blood pressure of 140 to 159 if they were on one blood pressure tablet and not controlled, or they had a sitting blood pressure between 150 and 179 when they're on no blood pressure lowering agents. They excluded various conditions which demand particular drugs. It's the usual thing. And as I said, the intervention was single pill combinations of amlodipine plus perindopril, or perindopril plus indapamide, or indapamide plus amlodipine. And as I said, the primary endpoint was 6 months ambulatory systolic blood pressure. After 2 months, the initial dose was doubled up, force titrated up, so long as the systolic was 120 and above. This came back to the don't go less than 120. So that's the design, and then the patient was seen in the clinic at 2, 4, 6 months, and at 6 months they had an ABPM at the beginning and at the end. All right. I won't show you the details, but amongst these Indian patients, 2,000 of them with uncontrolled blood pressure, either 0 or 1 drug, the 3 dual combinations produced almost exactly the same blood pressure reduction of ambulatory blood pressure. The mean reduction was 14/8, and in the clinic it was 30/14. So big reductions. There were no significant difference in the measure, any measure of blood pressure after 6 months of follow-up amongst the 3 combinations. It didn't matter which one. There were similar high rates of control. About 70% were controlled to less than 140/90. And 40% were controlled to less than 130/80 by all 3 combinations at 6 months. That's pretty impressive. So, the conclusion. In keeping with several current guidelines, I don't know if you can see this at the back, in keeping with several current guidelines, the TopSpin trial results suggest that the use of any dual combination from amongst ACE, dihydropyridine, and thiazide, any 2 of those 3 can be recommended for effective, tolerated, and safe blood pressure lowering in a broad spectrum of Indian hypertension patients. Okay? So you have evidence here that any 3 of those combinations are okay. Not shown here, and we presented this at AHA last year, the end of last year. We're still waiting for Nature Medicine to publish it. I'm not sure what the delay is, but it will be coming out. But when you get to it, you'll find that there were differences in metabolic effects, things that went along with the diuretic that you would expect. Glucose was up a bit. And so, for my money, I think you're better off with the calcium channel blocker and the ACE inhibitor of those 3 combinations because of the associations with the diuretic, which are there. I don't think our patients need help to become diabetic. And that is one of the slight side effects of the agents. So if I had to choose amongst the 3, I think the A plus C combo is the way to go. So if that's your combo, think about all the guidelines. Once you've had 2 drugs, if the 2 drugs aren't enough to get to your target, everyone agrees A plus C plus D. The only debate is which diuretic. thiazide or thiazide-like. It's very confusing. They call thiazide type. Now that's a thiazide or thiazide-like. Some guidelines actually call thiazide-like thiazides, and they're not. They are quite clearly different, and they shouldn't be confused. And in my money, I prefer thiazide-like. But again, back to pragmatism, I think your local guidelines were excellent. So, but everyone's agreed A plus C plus D is the way to go. So finally, ladies and gentlemen, this is how on the right we've traditionally managed high blood pressure. We get hold of an arm and we squeeze it, and then depending on how high the mercury column goes, we dish out tablets, ignoring the object that's attached to the arm. And we're going to have it, it's going to be difficult to prevent cardiovascular disease if we treat blood pressure like that. I think keep it simple is right, thresholds and targets, and keep it simple as the algorithm. I think that's fair too. But there are obviously some other things going off here. Too much smoking, too much booze, pregnant. It's got all sorts of problems which you need looking at and taking into account when we manage. And the cartoon's good though, because, let's break that wall down, it's good because it, in the cartoon, shows 3 tablets. Nearly all our patients need 2 drugs to lower their blood pressure, and many, about a third, are going to need 3 to get to 130/80. Not mentioned yet, but I think one of those should be a statin. I can't think of a reason why you wouldn't give a statin to a patient with high blood pressure. My patients get a statin. Doesn't matter what the cholesterol is, they get a statin, because that's the best evidence we've got for preventing cardiovascular events. So 2 drugs as basic for a blood pressure and a statin. And if you can give it as a single pill combination, they'll be much more likely to take the tablets. And that means they're much more likely to, or much less likely to have a cardiovascular event. Thank you for your attention. Any questions?
The salt preparation with sodium chloride 75% and potassium 25%, is it more expensive than the normal salt? Is that why people don't use it, or we don't have it in Sri Lanka? I was just wondering why we can't introduce that.
The low salt, it was actually a low salt product, it's called low salt, LO salt, but Saxa salt. Saxa is a very common salt. Do you have the Saxa here? No. Okay. They've got a 50/50 one. But the low salt currently available in UK is 66% potassium chloride and 33% sodium chloride. Is it more expensive? Yes. But Sainsbury's, one of the supermarkets, have got their own branded version, which is the same as ordinary salt. So it's all about training
the brain,
the cooks, really. If you, it's sexy now, and all the chefs recommend rock salt or sea salt, and worse still, Himalayan pink salt. Do you have Himalayan pink? That drives me mad in the clinic. I work in a very low socioeconomic area. Most of my patients are low socioeconomic. They can't afford Himalayan pink. And when I say, what salt do you use? I would think at least a third say, it's okay, doc, I'm on the Himalayan pink. Which is just very expensive sodium chloride. So has no value known to man. So, sorry,
and then, like, is there a taste difference in the two?
Yeah. If you taste it, well, first of all, the rock salt and sea salt, chefs like it because of the texture. It crunches, right? When you put it on, throw it on the top of the salad or whatever it is, there's a crunch. So that's why chefs like it. But if you put, and if you taste low salt, it tastes a bit different, slightly bitter. It's different. But what you put into your cooking for your rice, potatoes, pasta, whatever else you put in the cooking, you won't tell the difference. And that big trial, 21,000 Chinese patients they were 60 or above or had a stroke, it worked. I mean, they took the tablets. I think they took the salt, they changed, and despite there'll be a degree of non-compliance, if you like, it was about 4 millimeters, only 4 millimeters systolic, 3 to 4 millimeters, and you got those big benefits in cardiovascular events, so it's got to be worthwhile.
Yeah, thank you. I think Sri Lankans do eat a lot of salt. I think that is probably a good way forward, like if the ministry, and then we can, like, I mean, the big people can intervene in
Absolutely.
that.
You know, it's just a very simple thing to do. And you know, whether you're on an ACE inhibitor or an ARB, your RAS blockers work much better if you're on a low-salt diet. So I bang on. See, the commonest cause of salt on a British diet is bread. The bread that we have is stuffed full of salt. And people, they get up in the morning, they have a bowl of cornflakes and 2 slices of brown toast. It's okay, Doc, I'm on the brown bread. It doesn't matter, it's full of salt. So a bowl of cornflakes, 2 slices of brown bread, and they think they're doing a nice healthy breakfast. Murder. That's 2 days salt in breakfast. Cornflakes has got the same salinity as seawater. All right? Absolutely appalling. All the breakfast cereals with what we've got a thing called shredded wheat. I don't know if you've got that. That's got no salt in it. Puffed wheat, no salt. But all the other ones are stuffed full of salt and sugar, with neither of which you want. So one of the first things I talk about is the salt that they cook with and what do they have for breakfast, and change that and cut down on the bread. So I think they're practical things we can do. Please.
How safe is it used to HCT or thiazides in elderly patients, especially over 80 patients? We quite often see severe hyponatremia occurring with on patients who are on thiazides. So is there any other thiazides?
I mean, it happens. I think quite often is a bit harsh. Certainly, the very elderly trial, HIVET, used a thiazide-like diuretic, and that was well tolerated and reduced all the cardiovascular events a big way. So that's in the very elderly, 80 plus. I mean, I do take your point. I think indapamide's been associated with hyponatremia, rather more than the thiazides, perhaps. But I still use a thiazide-like and give them that chance. The evidence is for the elderly. That's the best evidence we've got is in the elderly for the thiazide-like and thiazides. I prefer thiazide-like personally, but you've got that from going back 30, 40 years in the isolated systolic hypertension. Dihydropyridine calcium channel blockers or thiazide-like diuretics is where the best evidence is for those 2 groups. But I do take your point. You've got to watch for it.
Thank you very much. Now, Professor Poulter, now, is there a place in supplementary potassium? We know potassium, dietary potassium is beneficial. So, yeah.
Yeah. I mean, the dietary supplements I give them is because it's in the salt that they cook in. They've got a chunk there, but also with the fresh fruit and vegetables as mentioned. We're not quite sure what it is in fresh fruit and vegetables that improves blood pressure. Fiber, potassium, nitrate, depending on which vegetables they are, all of which contribute. And of course, they're replacing other bad things. The fast food industry gets kicked into touch if you start using fresh fruit and vegetables. Well, it reduces anyway. But yes, so I think there is a place for that. Important. Can I just, please.
Hi, Neil. Thank you for the great talk. In the top spin study, were there differences in the tolerability between the groups? And the second, I have 2 questions. The second one is, why did you go for ACE inhibitor as opposed to an ARB in the study?
Okay, the tolerability was pretty much the same across the 3 groups. They're different things, but essentially it's the sort of things you expect. With the amlodipine, you're going to get ankle edema. With the ACE inhibitor, you're going to get a cough, etc. So the standard side effects were there, but overall they were equally well tolerated. We selected an ACE inhibitor rather than an ARB because we were able to get single pill combinations of all 3 products. So it was pragmatic. If you want my opinion, I think the ACE inhibitors are superior to the ARBs. I think the evidence for the ARBs is much less compelling. I don't know of any good evidence for ARBs in several settings. In diabetes, for example, what trial have we got with ARBs? What trial have we got ARB plus CCB? There isn't one. So for my money, I go with ACE inhibitors, but I think it's pragmatic. It's a sensible thing to do. Patients don't cough. But I don't treat hypertension to prevent cough. So, whereas I do use it to prevent cardiovascular events, and I think the evidence for ACE inhibitors is better for preventing cardiovascular events than it is for ARBs. And we could have that debate. I'll show that tomorrow in Jaffna, my thoughts on that. But I think to be pragmatic, I think, particularly if you've got it in a single pill combination where you're worried about the influence of the cough, then you would take the ARBs. But that's why we took it, because we've got 3 single pills with those 3 combinations in it. What about beta blockers? Oh, sorry. Is there a difference between amlodipine once a day and twice a day? Well, I would just say, why would you give amlodipine twice a day? It's got a 36-hour half-life. This is one of the few drugs where you can actually have what they kindly call a tablet holiday. In other words, and this happens when the patients forget or they don't take it over the weekend or whatever. Amlodipine is one of the few drugs that doesn't matter. But taking it twice a day, no, I wouldn't do that. I just can't think why we would do that. Can I just ask, what about beta blockers? Certainly in India, whenever I give a talk in India, at least half the audience stands up and throw things at me and say, well, you haven't mentioned beta blockers. And you mentioned it, but for 5 reasons to use beta blockers. And I think that's right. That's when beta blockers should be used. The evidence is they are less effective at preventing cardiovascular events than the other drug classes. And they are absolute. I mean, if you wanted to design a drug that was likely to give you diabetes, don't bother. It's already been done, and they're called beta blockers. This was the 2023 guidelines from Europe. These are the proper reasons to give, and you mentioned on your slide very simply why to give a beta blocker. Post-MI, angina, arrhythmia, pregnancy, and heart failure. No questions, beta blockers, good. But in this particular set of guidelines, suddenly they gave 497 other reasons to give beta blockers, none of which had any new evidence. Isn't that extraordinary? And yet the 2024 guidelines from essentially the same group, they dropped that lot. That disappeared from the algorithm. Why would that be? And I don't wish to be cynical, but first of all, you should ignore all that lot. There's one example here. It said, hypertension with elevated resting heart rate. That's the Indian doctors always say, but we have a lot of young men with a tachycardia. We should give a beta blocker. Okay. Well, that's the one they reckoned they should give. Here's the evidence from the Ascot trial. This was amlodipine plus perindopril versus beta blocker thiazide in the Ascot trial, and the amlodipine perindopril was superior to the beta blocker thiazide big time. That was really the death knell of beta blocker thiazides. That's when amlodipine, calcium channel blockers, and ACE inhibitors sort of took over on the basis of this trial. And we thought, well, maybe in those with a tachycardia, maybe the beta blocker group would do better. But here you go, stratified on baseline blood pressure from less than 60 to over 90. The benefits of amlodipine perindopril were maintained. There was no evidence that taking account of the pulse should influence your selection of a beta blocker. That's hard evidence. And yet, there it is. Nonsense. That lot, I'm delighted to say, have been dropped, and that's where they should be. Okay. And then finally, just to bring me back to the South Asian phenotype, this is why correct me if I'm wrong, but this is why you have high rates of coronary artery disease in the South Asian population, wherever the South Asian population go, not just here, but when they go to South Africa, when they go to the Far East, when they go to America, they have a 40% excess of coronary events. And my understanding is that's why they have. Does anybody disagree with that? Does anybody think I've got it wrong, or is there anything I'm missing? Please have a go at me if you think I'm wrong. Oh, well, it isn't a cut point. It's not dichotomous. There's a range right the way across. So, you know, that's typical that they have high, I mean, South Asian phenotypists have higher triglycerides than whites or blacks, for example, and lower HDL. So it's not a dichotomous thing, but they're the things. Anybody disagree with that? Right. That's what beta blockers do. Apart from lowering the blood pressure. They lower the HDL, they put your triglycerides up, they raise your sugar and they raise your insulin. They put your body weight, you put on weight on beta blockers, and they reduce your ability to exercise. Not to mention erectile dysfunction. All right? So, back to my thought. That's what kills South Asians, and that's what you're proposing to give South Asians for their blood pressure. I don't get it. I hope you agree with me. Okay. Let's move on to the next. Can you take it away from here? The next one. What's that? It's optimal timing of blood. Well, that's the one. Okay. This has been a debate for some time. Anybody got any comments before we kick off? Anybody think it's good to take, preferable to take the blood pressure tablets at night? Anybody think that? Okay, well, I won't bother giving the lecture then. You agree with me? All right. Well, there you go. This has been a bone of contention. Same conflict. What's the rationale? Why would giving the tablets at night be good? Well, this is what you look at, cardiovascular death by systolic blood, increasing systolic and increasing diastolic. This is the association of cardiovascular death based on clinic blood pressures, daytime ABPM, 24-hour ABPM, and nighttime blood pressures. And you see here this stronger association of nighttime blood pressures with cardiovascular events. So that's kind of the background. And if you add to it about nocturnal dipping, you know, the normal thing is that blood pressure goes down at night, nocturnal dipping. And this shows on the right the impact on survival, death. That's for people who do dip at night, and this is for non-dippers, those who don't dip at night. So non-dipping conveys a worse prognosis in death, irrespective of the 24-hour blood pressure level. Okay, so dipping matters. And the absence of normal dipping and the dipping size of magnitude predicts mortality in hypertension patients. So along with that great prediction that nighttime blood pressure gives you in dipping, people came up with the idea that we should take our tablets at night to make sure you get the nighttime blood pressures down. So what was the evidence to support nocturnal dosing? Well, there are a couple of lots of observational data. The big one was MAPEC for Hamida and Al in Spain. That was a big database, and I'll show you their data from the HYGEA study, and a Polish study as well. And then there were some other studies where in the trial, it wasn't compared with anything else, but within the particular trials, the tablets were given at night. So it's observational, there was no comparison in there. And the HOPE trial was a classic example. Do you remember the HOPE trial with ramipril was given at night against placebo? And they got remarkable cardiovascular events. Mean daytime blood pressure difference was 3/2, so tiny blood pressure difference, but big cardiovascular events. So that sort of promoted the idea that giving the tablets at night was the right thing to do. And some other studies here, CISTUR and CIS-China, also give and FACET trial, always gave the tablets in those trials at night, and they all were successful. So people said, oh, maybe nighttime dosing is the way to go. But then we did a study between us and some friends in Greece, and we compared daytime versus nighttime, just a trial, daytime versus night, crossed over to, and looked at ambulatory systolic blood pressure treatment, and then the HYGEA trial, that was the big one that came on after this HYGEA database, which really got things going. So this was our Greece trial. Hellenic, Anglo, can't remember what it means, but it's harmony. And basically we randomized our patients to receive their tablets in the morning or the evening, and then we crossed over. And the effect on the 24-hour systolic blood pressure was absolutely zero, no difference, no statistical difference both in systolic or diastolic ABPMs. They were identical in terms of affecting the blood pressure if you gave the tablets in the morning or the evening. The impact on the 24-hour blood pressures was the same. But here you see, this was the problem. HYGEA came out. A lot of our patients got downwind of this. Bedtime hypertension improves cardiovascular risk in this HYGEA chronotherapy, and this is the famous first author. Now, not only did it lower the cardiovascular events, but it improved the cardiovascular events massively. Here you see total events, total cardiovascular events, cardiovascular outcomes, strokes, coronaries, cardiac, minor events. These are 40, 50% reductions in cardiovascular events, depending on where you gave your tablets. Just wasn't going to happen, was it? I mean, but this got in the European Heart Journal, big fuss. Not only did you get those big benefits, but these are in different subgroups. Every subgroup, doesn't matter what the subgroups are. Here are all the benefits in the subgroups. Once again, about 40% reduction, irrespective of the subgroup. Now, I've been looking at cardiovascular trials for about 200 years now, and never in the field of cardiovascular medicine have I seen magnitude of benefits like that across all the cardiovascular events and all the subgroups. That never happens, ever, ever, ever. But it did, reportedly, in HYGEA. So everybody was going around saying, that's pretty strange, isn't it? When you take your tablets, either morning or evening, you get a 40% reduction in cardiovascular events. Really? So, this was an editorial that came in the Journal of Hypertension. There's some big names here. Giuseppe Mancia, Reinhold Kreutz, Chelson, Bernier. These are big names. And they said, disregard the reported data from HYGEA. Blood pressure medication should not be used at bedtime routinely. Ooh, it got a bit messy. This got a bit nasty, this correspondence. Why did they say that? Because they felt it wasn't a proper trial. They think it was just the MAPEC database, the original observational database, and they jiggled with it. There was apparently no loss to follow-up. Out of 19,000 people in this so-called trial, 607 were withdrawn. It's very small numbers, particularly since they were doing ABPMs very regularly. There was no adjudication or audit record available to be looked at. And as I said, the results seemed absolutely implausible. So, the editorial said, the reported data from the HYGEA project must be disregarded. BP medication should not be routinely dosed at night. And then we got this. This was a comment from the International Society and World Hypertension and the ESH to try and offset the panic. I don't know about you, but I had patients saying to me, should I take my tablets at night? It got out there. It was sexy. It came into the press. But in the Journal of Hypertension, 3 ongoing, well-designed, prospective, randomized, proper randomized controlled trials, brackets, we don't think HYGEA was, are expected to provide high-quality data on the efficacy and safety, blah, 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 blah. Until this information is available, preferred use of bedtime doses should not be routinely recommended. So they said there are 3 trials on their way, hold fire, let's see what happens. And the time study I chaired as the independent chair of this trial, the time study, and published 3 years ago now in The Lancet, and this was a properly randomized trial, giving the patients their tablets at night or in the morning. They were randomized to that and followed up to look at the cardiovascular outcomes. Prospective randomized trial, unlike IGEA, 21,000 adults who were on one or more agent. And they got the morning dosing, which was 6 till 10 or 8 till midnight. And the primary endpoint was cardiovascular death, non-fatal MI. That's the classic 3-point MACE, right? And the median follow-up was 5 and a bit years. And here are the results. For the primary composite, which I've just shown you, triple endpoint, then subdivided, the 3 subdivisions, and all-cause mortality. And these are the event rates for whether you got the tablets in the evening or in the morning. And you see here absolutely no difference between the 2 groups. That's a properly carried out trial. So we concluded that evening dosing of usual antihypertensive medication wasn't different from morning dosing in terms of cardiovascular outcomes, and patients can be advised to take their regular drugs at a convenient time that minimizes any undesirable effects. In other words, wherever you're most likely to take the tablet, do it. If you like the morning, lunchtime, night, whatever it is, assuming you're going to use drugs that take 24 hours, right? That probably, it might make a difference. The conclusion with the other 2 trials was BEDMED and BEDMED-FRAIL. These were small trials in Canada, and they came in and they had the same results of time, essentially. No difference whether you gave the drugs in the morning or the evening. No signs that benefit or harm with bedtime compared with morning in properly conducted trials. And they did a meta-analysis, including IGEA, for all that most people think it was, what's a nice way of setting science fiction. Here you go. They included IGEA, and that showed no benefit at the evening versus morning dose. So I think it's clear, the evidence, it doesn't matter. It's just important that you find out when suits the patient and tell them to take the tablets then. Advise patients to take once a day medications at whichever time suits them and optimizes adherence. I think there's one possible caveat to that, and that's if you're using short-acting agents, maybe you might be better taking them at night. See, ramipril has gone at 40, if you use ACE inhibitors, ramipril is the most commonly used, is gone at 20 hours, which is why I use perindopril, because it isn't. But ramipril is the most common drug used. And in UK, I don't know about here, there's a horrible tendency to start ramipril at 1.25 milligrams, and then 3 months later, double it dangerously to 2.5 milligrams. And then about 20 years later, it gets doubled to 5 milligrams, which should be the starting dose of ramipril. If you're going to use ramipril, start with 5. Be brave, bold, bloody. Start with 5 and then double it to 10. Do not mess about with 1.25 and 2.5. Waste of everybody's time. But it may well be that if you're taking the short-acting agents, and our Hellenic trial, our Harmony trial, I suppose because we were both hypertension units, I think both units tended to use long-acting agents, so they use once-a-day agents, so we showed no difference. But the time trial was much more generalizable, I think, and showed that it's the case. It doesn't matter when you take it. And what about non-dippers? There's a high rate of non-dipping in South Asian patients. We can tell you, we haven't published it yet, but in the Topspin trial, non-dippers amongst the South Asians, this was 35 sites in India, non-dipping rates were high. And maybe if you're going to use a short-acting agent and you're a non-dipper, maybe nighttime dosing might be okay. Okay, any questions about that? You all agreed with me before I started, so I was preaching to the converted. If there are no issues, let's go on to the third talk, which is about resistant hypertension. And this is fairly pragmatic. This is really for the medical officers out there, just some practical advice how to what to do about resistant hypertension. And then we'll just run through a few cases just for fun. How are we doing time-wise? We're doing all right. All right. There we go. Me again. Even my mother wouldn't want 3 of me in a row, but there you go. You got me. Resistant hypertension. Just a practical approach to management. Same conflict of interest. How do we define it? Well, I think it needs defining and clarifying, because as you'll see how you work through the practical approach to it, you need to have this in mind. And it's uncontrolled blood pressure of 140 or 90 in the clinic. Now, in UK, we demand NICE. We've got a thing called the National Institute for Clinical Excellence, NICE, and they're not always, but they introduced quite a long time ago now, over 10 years ago, that to make the diagnosis of hypertension, general practitioners had to do either home blood pressure monitoring or ABPM before it could be classified. And there was money associated with that for the GP, so it came into standard practice. So you need that, plus either the home blood pressure recordings 135/85 or a daytime ABPM of 135/85. Between you, me, and the gatepost, the BIHS are about to drop this to 130/80 as their target, even with the ABPMs and the daytime ABPMs or home blood pressure monitoring. But that's hitherto how we've defined resistant hypertension. And it's got to be in the context of a half-decent lifestyle. On Wednesday, I had a patient who was 170 kilograms in body weight. 170 kilograms, who'd been sent to me because they were worried. They were a little bit worried about their blood pressure. Amazing. Quite commonly, I'll see patients with over 140 kilograms. Absolutely standard. We have special weighing scales. So if you're fighting against that amount of fat, and one of the big problems with that sort of body weight is that the arms are very often conical shaped, aren't they? You know, the top of the arm, they go up like that. And you've no idea, when you've wrapped the cuff, you need the world's largest cuff wrapped around them, and you have no idea what the blood pressure is really. And you use the thigh cuff and you think, well, maybe that's right. The evidence for those huge cuffs is pretty dodgy. So if you're doing that, you're also on a massive salt load, because you're eating a shed load of salt, because you're in fast food and all the fast food outlets are full of it. I worry about the genetics of obesity. Save the money and close McDonald's and Coca-Cola. That's the way. But anyway, if you've got this massive tsunami of rubbish in the diet coming at you, it's very difficult to control blood pressure. So I think that needs to be considered for it to be real resistant hypertension. Then next, you're supposed to be on the optimal or the maximum tolerated dose of at least 3 antihypertensive agents. And as we've said, it's the usual 3 we've talked about: RAS blocker, calcium channel blocker, and in UK we say thiazide-like diuretics. But I take the point here that may not be the form. It doesn't matter. RAS blocker, whether it's ACE or ARB, dihydropyridine calcium channel blocker, where the evidence is, and thiazide-like or diuretic thiazide, if you like. And then you've got to exclude not taking them. And we'll come back to that in one of the cases. Not taking the tablets, you've got to try and make sure that's not the case. And you exclude secondary causes of hypertension. Once you've thought about all those things and you've got that, then you've got resistant hypertension. What are the associations? Who's more likely to have resistant hypertension? Well, no surprises here. Older age patients, those of African Caribbean origin. Interestingly, in sub-Saharan Africa, blood pressure tends to appear earlier and gets more severe. And you get more left ventricular hypertrophy, etc. Non-dipping is a big problem in African Caribbean patients. Low socioeconomic status, low income, obstructive sleep apnea goes along with obesity story and alcohol, of course. Depression. It's an interesting association, but it's been recorded. And those at high cardiovascular risk tend to have resistant, or more likely to have resistant hypertension. Carrying on the list, hypertension-mediated organ damage, obesity, you can see the links here, chronicity of the blood pressure elevation, those who've had it since they were 25 are more prone to get resistant hypertension. Whether that's accumulation of them, of lack of taking their tablets, they're bored with the whole thing, they're very often overweight. Low physical activity, and these two are interrelated. Being obese prevents you from doing physical activity, and not doing physical activity makes you more prone to obesity. Excess booze and high salt intake. All these things are associations, no surprises there, nothing particularly clever. But if I was to say to you, what percentage of people have got resistant? Amongst hypertensives, what percentage are resistant? Any takers? Anyone want to shout out a number? What percentage do you think it is? Anybody? Come on, have a guess. 20%. Most people quote high rates like that, 20%, but I think it's because it's mixed up with all those other things that cause the resistance, and they're not really resistant. They're just either not taking it, or they're 250 kilos, or they're drinking 3 bottles of wine a night, etc. So that's about the prevalence. Now this next slide, and I apologize you can't see this, I was horrified this, teasing out, it's really to go through that list that I mentioned at the beginning, screening. So first of all, as we said, you've got to have the blood pressure level 140/90, or with home readings, being on the 3 drugs. That's the first thing. You agree that 3 drugs at maximum tolerated dose, and they're above the levels we talked about, 140/90, that's going to come down in the clinic, 135/85 outside. So then get rid of pseudo-resistance. This can all be done by the general practitioners. This is a British Hypertension Society chart. So it's for the GPs at that point to verify accurate blood pressure measurement. Is it really elevated? That's important. And then, as I said, because it's nice, you've got to do out-of-office measurements, the home and ABPMs, and we need some sort of evidence for adherence to the drugs. I don't know what you do, but our patients, if anybody's on 4 drugs and not controlled, we take a urine sample and we send it off to Leicester, which is in the Midlands in UK, and for £30 they analyse the drugs. And the patients aren't taking the tablets a lot of the time. They may be taking 1, 2, 3, but they're not taking 4. Rarely are they actually taking the 4 drugs. The metabolites are not in the urine. So that's the next thing you have to do. We want to support adherence. Before the Leicester deal came up, we used to bring the patients in, 2 outpatients, and we'd say, don't take your tablets, come in, and then we did a tablet feed. Now, the danger of doing that, if you give them the 5 tablets they say they're taking, if you give it to them, they faint because they're not taking them. So our tablet feeds consist of giving them half the tablets they said they were on, and you give them little bits and feed it until making sure they don't faint. And then we did a 24-hour tape after they'd received the full dose of whatever they claimed to be taking. That's what we used to do, but now we send things off to Leicester. So once you've established the blood pressure really is up, that they really are taking the tablets, and you've got confirmation from home blood pressure and ABPM, then once again, the management, you look at the modifiable causes of hypertension. This is the salt and all the rest of it. And you can exclude drug causes of hypertension. I've got a list coming up of the drugs that cause raised blood pressure, things like the oral contraceptive. And then you've got to consider secondary causes, and so you do a few tests for that. And then you optimize the therapy, the 3 drugs we talked about, ideally ACD, so RAS blocker, calcium channel blocker, diuretic. And then 4th line, a recommendation, as you suggested, is to add in spironolactone at low dose initially. The problem with spironolactone is gynecomastia for the men, sore breasts, nipples for the women. But if you put it in at 12.5 milligrams, which I tend to, if the patient's potassium's up a bit, I give 12.5 and watch. Bear in mind the creatinine will go up. That's okay. You just got to see how far it goes up. And the potassium also is going to go up a bit. So you've got to be cautious with that. So that's the sort of management at the GP level. And then you send them off to secondary referral here. I do apologize that this isn't clear for you. And then, of course, when they come to us in a hypertension clinic, we investigate the secondary causes of hypertension. We confirm adherence from the urine test I told you about. And then we look at we've reaffirmed the modifiable causes that we talked about. And then we've got a standard management plan for what to do. And the 4th line is spironolactone. I tend to use slow-release doxazosin alpha blockers as a 5th line agent. So I like doxazosin slow release. The normal form of doxazosin a bit more prone to cause dizziness. And nearly all these patients, particularly as they're older, complain of dizziness at some time of day. So I don't use doxazosin unless I use the slow-release formulation. Anyway, here are the things you've got to think about that the patients might be taking that puts their blood pressure up. So this is sort of getting rid of these, if you can, to really prove that it really is real resistant hypertension. Cocaine, a lot of it about, depending on the sort of age and social class. Decongestants, so lots of the Otrivin. Do you have Otrivin for nasal decongestants? They tend to put your blood pressure up. Bronchodilators, antidepressants, NSAIDs, the combined oral contraceptive pill, steroids, licorice, and many of the antacids contain sodium. So be conscious of these, and by changing those, if you can sometimes, then that makes the blood pressure easier to control. Okay, so that's what puts the blood pressure up. Then what are you going to do is to give them, and we talked about this in the last lecture, these are the things that you're going to recommend. Particularly, my focus, as I've mentioned to you, is the low salt. I do that. So, what about the drug sequencing? As I said, we've all agreed A plus C plus D. Whatever guidelines you follow, it's A plus C plus D. It's the standard triple. And then you add in whatever your favorite drugs are. But the evidence, the best evidence for 4th line agents is spironolactone, which is why it's in your guidelines. And then, as I said, I like doxazosin. You don't have to measure anything. It doesn't affect, well, it has a beneficial effect, if anything, on lipids. And interestingly, of all the agent classes, this has got the best evidence for erectile dysfunction, not causing it, preventing it. So whenever I've got a male that complains about erectile dysfunction, I think about doxazosin as a potential use. And of course, lots of our patients are old and male, so they've all got big prostates, and the doxazosin helps that too. So it's a good, handy drug for using for older patients. Then the long-acting beta blockers, my favorite's bisoprolol, but I'm struggling now. I'm now 3, 4, 5, I'm 6 drugs in before I use beta blockers. And then we're really getting into trouble. But lots of excitement these days with the SGLT2s and the GLP-1s. Evidence in obesity without diabetes, the GLP-1s, semaglutide works, lowers the blood pressure, lowers the systolic a bit. And I can see a time when we may be adding in semaglutide to any, in the same way we add statins to our patients with hypertension, that we might be using, just a routine. There you go. Let's have some semaglutide. There is an oral version of semaglutide which is going to come through. The SOUL trial has just been published. Impressive. Alternatives. If we can't tolerate, and one of the reasons why can't we tolerate amlodipine? What's the big problem with amlodipine? Clue. Ankle edema, yeah, that's the problem. Now, not many people believe me, and I can't get the trial organised, and I probably won't. But if you give your amlodipine at night, you are less likely to cause ankle edema. Now, when I was told that a couple of years ago, I said, that's rubbish. Why would that be? With a drug that lasts 36 hours, why would giving it at night help? And then my wife, the same one who won't drink beetroot juice, was on amlodipine, and she said during the summer, and that's when you get most of this swelling of the ankles, it's more like you permanently got summer, but standing up in hot weather, you're much more likely to get it. When you wake up in the morning, amlodipine-driven ankle edema isn't there. There's a clue. But it does happen in a proportion. It stops you using it in some patients, particularly younger women. You know, it's absolutely not compatible with certain shoes. So you've got to get that right. But if you take the tablets at night, you are less likely to get that. Try it. I know the reason I swung over to believing it was when Caroline said to me, I've got swollen ankles one summer. I said, well, take it at night. And she did, and it went away. Amazing. N of 1 has persuaded me. And since then, I've tried it on my patients too. And it doesn't work on all of them, but it does work in a proportion of patients. And then, of course, you'll appreciate finerenone, exciting stuff. There's trial evidence of using chlorthalidone in CKD now. Tiny dose of chlorthalidone in CKD, just very gently up titrating, starting at 12.5. Eplerenone as an alternative to spironolactone. Spironolactone, as you know, the gynecomastia, etc., the eplerenone doesn't cause that. But you need about 3 times the dose. So if you're on 25 of spiro, you'll need 75 of eplerenone to get the same blood pressure lowering effect. But you won't get the gynecomastia. So that's a good alternative. And some people like amiloride. I was never been so impressed with that. But there are the alternatives that I think you can think about. So once again, I'm going to show you something that you can't read, but it really pulls together what we've just said. You've got the suspected case of resistant hypertension, get it measured properly, concomitant medications, make sure the adherence is there, consider secondary causes. Then you go to optimize the treatment, check the dosing, long-acting formulation, use single pill combinations if you can. And there are now triple pills. There's a quadruple pill coming through, but there's a triple pills which have been tried in quite large numbers now. It's gone through the FDA. They're going to become available. And then we add in spironolactone, and as they go, in case of intolerance, think of it amiloride or eplerenone, as we've just said, and then finally go to the hypertension specialist. So that kind of summarizes everything we've said, and there's the modifiable non-pharm things you want to think about there. Okay, any questions about that? It's all fairly didactic. If you want those slides, we can make them available to you if you'd want them, just as a handy sort of checklist. All right, any questions, anybody? If not, we'll just bang through a few cases. This gentleman's age 58. He's a white office worker, and he was diagnosed in 2017. And he's had really bad blood pressure control since 2017. His therapy is an ARB, top dose. He's on aspirin. Hydrochlorothiazide, 25 milligrams, top dose. Atorvastatin, 80 milligrams, top dose. Amlodipine, 10. And isosorbide mononitrate and a GTN spray. So this guy's got angina, which is why he's on aspirin. What about in primary prevention? Anybody use aspirin in primary prevention? Good. You shouldn't. Aspirin should be reserved for those with established vascular disease, I think, and low dose. Good. But there he's on a shed load. He's in top dose, top dose, top dose, top dose, and anti-anginal therapy. And he's got badly controlled blood pressure. His past history, he's got the blue puffer for his asthma. He's had an AMI with an angioplasty, hence the high-dose statin. What proportion of people who've had an MI are sufficiently controlled on a high-dose statin? How many people think the majority are controlled on a 2 over 80 to get to current targets with the LDL? Speak to me. Is anybody out there? What proportion? Well, it's not many. Okay? Dual therapy is big time amongst the lipidologists these days. They're all trying to persuade you to add in something else. Ezetimibe being the obvious first choice, but then getting into inclisiran has been increased within UK too. But anyway, he was diagnosed having obstructive sleep apnea. He's overweight, obviously, and he's on CPAP, in theory. Family history, his brother, age 42, has got a raised cholesterol, so this is making you think this is FH. He's had an MI. How old did we say he was? He was 58, I think, wasn't he? So 10 years ago, 48. So this sounds a bit like FH. And his father died age 68, don't know why, probably an MI. He's a non-smoker, doesn't drink alcohol, poor chap. He's got limited fresh fruit and vegetable. He's on too much salt, fat, and caffeine. I ask about coffee ever since I had a patient who was Irish, and he'd driven across UK to come to the clinic, and he'd got good going hypertension in his 40s. And I did the usual story, the whole history. And he said, oh, there's just one more thing. I said, what's that? He said, well, I'm addicted to Red Bull. I said, what? He said, yeah, what do you mean you're addicted? He said, well, today I've had 10 cans so far. And once I've gone home, I'll have another 10. He's on 10 to 20 cans of Red Bull a day. It's a bit like the guy who's 170 kilos. You know, so well, stop it. And I said, it's easier with Red Bull. And he did stop it, and his blood pressure was normalized. And that really, you know, there's been debates about whether caffeine is good or bad and all that stuff. I think it puts your blood pressure up, all right? So 4 large double espressos in the morning is going to put your blood pressure up. So that's worth knowing about. And he had all those things, and he took very little exercise. Body mass index, not bad, 26.5. I mean, it depends where you are. Would that be large here? Yeah. See, normally 30 is what we work on, but you guys got a different sort of idea, quite rightly. Nothing in his heart, no signs of heart failure, peripheral pulses normal, no stigmata or secondary causes of hypertension. But when you say no stigmata of familial hypercholesterolemia, you've got a good family history, and that would do for me. So his investigations, potassium normal. I'm sorry if some of these units aren't right. LDL, so that's 200 milligrams. Non-HDL, 6.1, that's horrible. The trigs are up. Fasting triglycerides, multiply that by 90 to get it to whatever you like. Thyroid function normal, HbA1c was normal, is lucky. And we did the urinary drug concentrations as I promised you. I threatened before, and this is the result here. Not detected, not detected, detected, and detected. So he was taking irbesartan, an ARB, in a 60-year-old. The RAS blockers are not great as you get older, because in older patients, the renin level is down, and the RAS blockers work best when your renin levels are high. So that's not going to do much good. And this is the sort of spiel you get with it. The stated half-life of amlodipine is 35.7 hours. This medication may not have been investigated for at least 142 hours before this collection. So you can't say, oh, I just forgot that morning, doc. They hadn't been taking it. So we use this, and that helps to drive practice. So it's just a message. Whenever you've got people on several drugs, are they taking them? Now, here we've got a 32-year-old office worker with blood pressure up, and he found out because he went to the gym, and he did a medical, and he was overweight, was a big chap, and he had a pretty sedentary lifestyle. He also was a smoker, but otherwise he was physically normal. So what would you do with a case like this? you've got to repeat the blood pressure measurements. One-off readings won't do. And in a gym, what sort of machine was it they're using? Probably 50 years out of date. The other thing is, what size cuff? I think this is absolutely pivotal, particularly in the gym setting. You got these people who are humping weights around and they've got very big guns. They've got big guns. And they go along and they get their blood pressure measured with a normal size cuff. Somebody answer the phone. With a big cuff, and they do it with a normal cuff, you're going to get spuriously high blood pressure. So be careful with gym-based that. How big's his arm and what was the cuff size? Look in the urine, proteinuria, ECG, fasting glucose and lipids, renal functional electrolytes, 24-hour ABPM, or all of the above. Well, I'd go for G, all of the above, because that's pretty much our standard test that we do routinely. That's what NICE would recommend. ECG is done routinely. Why? Well, ischemia and arrhythmias, maybe. I probably, of all the things here, I get less value. The least value I get is from urinalysis. I'm not a great believer in proteinuria. And I know it predicts cardiovascular events, but what are you going to do about it? And the answer is you're going to lower the blood pressure. So I don't get a lot out of that, and we don't get routinely a hell of a lot out of ECGs, but I think it's probably you've got to do that. So they're the things I would have done on this 32-year-old. And here you see his ambulatory blood pressure monitoring was low. That's 130/85, 135/85. That's where it should be. And look at that. It's down, and the pulse rate's down. So, urine dipsticks were negative. His cholesterol, well, the LDL's up a bit. HDL's down a bit. 0.9, that's a little bit down. The trigs, well, that's for us, that's borderline high in a fasting sample. Fasting plasma glucose was okay. Sodium, potassium, creatinine, all okay. Big chap, hundreds okay. I get terrified about estimated GFR. Anyone over the age of 60, they've been terrified by the renal doctors and told they're in renal failure. Because the creatinine, perfectly normal creatinine, and they come in absolutely terrified. I'm dying, doctor, I need dialysis. No, you're not. So, there he was, normal. So that's the sort of thing with sort of moderately poor lipids. So it's probably spurious hypertension, and that's probably the poor measurement technique. In the gym, if he's got a fat arm, he'd got the wrong size cuff, or the machine was no good. But overall, because he's young, his absolute cardiovascular risk was low, but his lipids weren't great and would respond to cardiovascular or other to non-pharmacological advice, lifestyle advice, smoking. What does smoking do to your lipids? Well, if you stop, your HDL goes up. That's the big advantage. Body weight, he got too much, and exercise, that would increase his HDL, and losing weight would increase his HDL, and he needed that. And the weight would lower the trigs, lower the total, increase the HDL. That would be good. All right? So, spurious hypertension through measurement error is common. It's pivotal that we measure the blood pressure right. Okay, now we're going to a 34-year-old woman who came in with blurred vision and headaches into casualty, A&E, ED, depending on what you call it. Previously been quite well. She takes the oral contraceptive pill, combined oral contraceptive pill. Previously, her blood pressure had been okay, and she was conscious and rational. She was rational, not rational, she was rational and conscious. So, what do you think? Any thoughts? Anything you'd worry about? Anybody? Well, there's the blood pressure in both arms. That's the other thing, you know, when people go into A&E and they're blurred vision and they're worried and they're feeling sick, they're frightened. And so many of the blood pressures you hear about when people are frightened. They're raised, and they're spuriously raised. And one of the things about home blood pressure recording is that I do it routinely. I think it should be done in a standard way. And that is, you take 3 readings in the morning together, not at 9, 11, and 1 o'clock, but 3 readings together, a couple of minutes apart, and then about 12 hours later, 3 readings together. And you do that 7 days a week. That gives you home readings. And I average the second and third. I think that's the way to do it. But what very often happens is people, they get obsessed with their blood pressure at home, and they get a headache, they feel dizzy, they panic, they put the machine on, and of course it's high. Then they're really worried. So then they phone their GP, who says, call an ambulance. So now they've really got high blood pressure. The ambulance shows up, and it's now 200 over 120. And they're, oh, we better take you into casualty. So then they go into A&E, and luckily you have to wait about 6 hours when you get to A&E in UK. So they sit on a trolley for 6 hours, fall asleep, and their blood pressure comes down. Nevertheless, the casualty officer says, you ought to go to a hypertension clinic. So we get all this sort of rubbish sent up to us on the basis of never having the blood pressure measured. I say to my patients, do not measure your blood pressure when you've got symptoms. The only exception to that is if when they stand up and they feel dizzy, okay, now check your blood pressure. Is it because it's low? Fair enough. But high blood pressures, when you've got a symptom, mean nothing. So you've got to worry about this. This woman's very worried. She's got blurred vision, and she's been fine before, so she's anxious. Now, she's got a displaced heaving cardiac apex. You don't need, if your left arm's doing that, you know there's a problem. Papilledema, retinal exit, and hemorrhages. Loads of protein and blood. Any diagnoses yet? Anyone going to give me a diagnosis? She's not very well, is she? Good. All right. Here you go. LVH and strain. And problems. Hemorrhages, exudates. So this is a problem. So, I've said one correct answer, I'll probably give you 2. This patient should be treated. Who thinks this should be looked after as an outpatient? Well, I think you could. She's rational. She's okay. She's just got a bit of headache. You could do. It's possible, I think. Now, you need to bring down her blood pressure quickly over the next few hours. Anybody think that's true? Good. It isn't true. That is clearly not true. Intravenous medication? No. No, this is not an emergency. This is an urgency, but it's not an emergency. Capsular nifedipine. Who would use capsular nifedipine? Good, no one. If you have capsular nifedipine in the pharmacy, go and get it and throw it out. It shouldn't be used on anybody. It's a favour to some of the obstetricians to give capsular nifedipine. This is a dangerous drug. It should not be used. When you have very high blood pressures like this, dropping the blood pressure quickly is a dangerous thing to do. So what we tend to do is use low doses of an oral agent. And interestingly, this is one of those rare moments where you might well turn to a beta blocker. You use the liquid form of atenolol. You can give that in little bits, just liquid form. We also use a sort of medium-acting calcium channel blocker. Don't use amlodipine. It's a bit slow in onset. We use medium-release nifedipine in that sort of setting. That's the stuff we would use here. So that's what I think you should do in this situation. I think that's a bit harsh. So if I had to say one, I think that's correct, but I think that may be correct too. I think it could be measured. Initially, though, you're going to give the agent in the department, and if things settle down, you could probably let her go home and bring her back pretty soon. Your further management is going to be, you've got to evaluate, is there a secondary cause of this? She's in her 30s with severe hypertension, with severe hypertension-mediated organ damage. So, you've got to stop the pill. Now, be careful. Where is she in the cycle? What's the contraceptive status? Because there are more strokes due to pregnancy than there are due to the oral contraceptive. So be careful when you do that. And then for her contraception, you can change to a progesterone-only pill, which are less likely to raise your blood pressure if she needs contraception. The other thing just reminds me about if you're on a RAS blocker, as a woman, you must not get pregnant. And that's something I think routinely you should be saying to your patients. If they're on a RAS blocker and they're less than 50, i.e. having periods, then you need to discuss the contraception situation and make sure, and write it down, make sure they know that they should not get pregnant on their RAS blocker. What tests are you going to do? All the routine ones we talked about before, and then put her on a routine antihypertensive regimen. She wasn't on one before. So, now then, this is a fourth patient. He's been hypertensive for 5 years, no secondary cause, he's been investigated, no secondary cause. He's been in and out of the doctors and poor control, and he smokes 15 a day. He's trying to kill himself. And look at his treatment. This is old-fashioned, okay? Atenolol, high dose, captopril, TDS. Some of the comparisons between ACE and ARB, there's a belief that the ARBs lower the blood pressure better than the ACEs, and that's because the comparisons sometimes involve these short-acting ACE inhibitors when they were given once a day. I mean, if you're going to give captopril, it should be TDS, but I would recommend to you that if you are going to use an ACE inhibitor, once-a-day ACE inhibitors, and that really means perindopril. Trandolapril is equally long-acting, but less trial evidence to support its use. But that's the regimen, okay? High-dose beta blocker, right? Atenolol, captopril 3 times a day, and bendraflumethiazide. Do you use that here? Have you got bendraflumethiazide? No. I don't know why we did it in the UK. We have, though. We used to have it at 10 milligrams 100 years ago. All right, on examination, this guy's overweight, his blood pressure's sporting, his heart rate is 96. What does that tell you? What treatment was he on? Atenolol 100, right? Oh, no, he's not. Proteinuria, AV nipping, so secondary changes there. LVH and strain, his creatinine's up. That is up. And fasting plasma glucose is getting up there too. Now, the glucose tolerance test, based on that fasting glucose, confirmed he'd got diabetes, and here's his lipids, raised LDL, low HDL, and trigs, higher range of normal, fairly typical for a diabetic patient. And then just confirming the diagnosis, he's got it big time. There you see, he's got elevated. There's 140, there's 90, there's sort of clinic readings, 135, 85 being the ABPM normal range during the daytime, but there you see it, and there's no dipping. People with secondary hypertension, severe, obese, all those things are more likely to be non-dippers. So, what does he need? Well, we need to address his adherence, don't we? He's clearly not taking his tablets, and you've got to front up to him and tell him. There is an issue in our system because we send the urine off, and it comes back saying, not detected, not detected, not detected. And then you can say, are you taking your tablets? Yes, no, you're not. How do you know? Because it's here in your urine. Now, my colleague did that to a lawyer. And the lawyer didn't like it one bit. So we had a tricky time and went through our ethics. In theory, we're supposed to tell the patients that we're doing it. But you don't tell the patients you're going to do the liver function tests, do you? But nevertheless, we're supposed to tell the patients. And I do in a roundabout way. I say, well, I just want to know how you're metabolizing the tablets. So just give us that urine sample. Or usually I say, you know the urine sample you gave us? We're going to just look, see how you metabolize the drugs. Is that okay? Yes. Tick in the notes. Got it. But make sure you got the urine sample first, because otherwise you say, I'm going to collect your urine to check. They're gone. Because they know. So, diet and lifestyle, smoking, his body weight. He needs a statin. He's got type 2 diabetes, metformin, and then all the other wonder drugs we've got now. Guess what the commonest drugs that are being used for diabetes now? No, the gliptins. Are there any diabetologists in the room? You're being honest to me. No diabetologists? Marvellous. Well, it is totally unbelievable to me. When you say to a diabetologist, why are you using a gliptin? They say, well, they don't get hypos. I will give them a placebo. They won't get a hypo on that either. You're treating their diabetes to prevent cardiovascular events. You have drugs that prevent cardiovascular events. Why do you not use them? Oh, I don't get a hypo. Oh. Anyway, really exciting times, aren't they? Now, aspirin, that's a big question. What about aspirin in type 2 diabetes? What do you think? I don't. Unless they've got cardiovascular disease, I don't do it. A hemorrhagic stroke or a hematemesis, I mean vomiting blood in accident emergency is one of the horror situations in life. And hemorrhagic stroke, I just can't face the responsibility for that, so I don't do it unless they've had established vascular disease. And then you're going to jiggle around with your antihypertensive medication, bearing with the fact this guy isn't taking his tablets. Why isn't he taking his tablets? Because you're giving him a beta blocker with all the horrible things that does, along with a diuretic. That's pretty good for erectile dysfunction. And if you speak to him, enough middle-aged men about their sex lives, they'll tell you, not good. So you've got to explain that the tablets you're going to give are less likely to cause erectile dysfunction, etc. Now, we talked about combinations. Which one would you most likely use? Now, I've just slagged off A. Anybody vote for A? Would anybody have given A? You wouldn't dare say it now, would you? Would anybody give A? Good, you wouldn't. What about ACE inhibitor plus a diuretic? Well, it was equally effective in topspin as the other drugs, but there were slight metabolic effects associated, even with the thiazide-like diuretic, which is pretty good. Slow release indapamide, 1.5 milligrams, is relatively metabolically friendly, but it does cause it. What about ARB plus a diuretic? That's a very commonly used combination around the world. Anybody use that? Best evidence for ARB plus a diuretic is the LIFE trial. That was losartan plus a thiazide versus atenolol plus a thiazide. That was the first trial that got the ARBs on the cardiovascular map. Before, it was all about, it was good at proteinuria. Who cares? But that's how the ARBs were introduced. One New England Journal article edition, there were 3 papers showing the benefits of the ARB class on different renal function. But yeah, that LIFE trial, losartan versus atenolol, and they both had a thiazide added to it. And the overall benefit was in favor of the losartan thiazide. But that overall benefit was all down to stroke reduction, which atenolol doesn't do very well. And actually, the coronaries were prevented better by the atenolol than it was by losartan. 9% in favor of the atenolol. The stroke reduction, 23% in favor of losartan plus thiazide, gave the overall 13% reduction significant. And that was the birth of the ARBs. ARB plus dihydropyridine calcium channel blockers. I think that's what perhaps you would start with here. Again, with my reserve about that, because there's no trial evidence of that combination. And that's my favorite, ACE plus dihydropyridine. But I think here, those two are the ones that you're most likely to use. And I thoroughly understand the use of losartan in that setting, along with the dihydropyridine calcium channel blocker, taken at night to avoid swollen ankles. And that's the lot. Any questions about that? Oh, we're finished. Time to finish. Sorry. Okay, if there's no more, thank you for your attention. You mentioned to give one steady dose as much as possible. Is the benefit trial proven? 24-hour blood pressure control is absolutely proven, yes. What you need is 24-hour control. It's also proven that adherence goes down if you give BD regimen. All right, so for every reason, yes, is the answer to that. Similar to non-nocturnal, is CVD predicted by morning surge? Yes, it is. It is, yeah. And that's again why you need 24-hour blood pressure control. Is being beneficial, surge is being beneficial in resistant hypertension. Is that linked? Is CVD predicted? Sorry, is there evidence that practical of mindfulness is beneficial? I don't know if there is evidence. About 50 years ago, Chandra Patel did a lot of work on what would be essentially mindfulness. It was yoga, really. It was positional. And she showed that certainly during blood pressure being taken, the blood pressure came down just when they were sitting in mindfulness. But the 24-hour blood pressures were unaffected. So that lost momentum, I think. Losartan 50 BD or 100 daily? Well, it's a good point. 100 daily will give you, pretty much give you control. Losartan, again, is a little bit shorter acting. It's not as bad as, well, it's about the same as Ramipril, actually. It doesn't give you the full 24 hours. But if you give 100 milligrams, you will get pretty much that. BD, 50, anything BD is less likely to be taken. So I go to the once daily higher dose of drugs like that. Have I answered all the questions?
Thank you, sir, for that insightful session. So with that, we have come to the end of today's program. And to conclude the program today, may I invite Dr. Rakita Higgoda, Honorary Joint Secretary of Sri Lanka College of Internal Medicine, to deliver the vote of thanks.
Good afternoon, ladies and gentlemen. It is indeed my pleasure, on behalf of the Sri Lanka College of Internal Medicine, to deliver the vote of thanks at the conclusion of this timely and important event, the update on the management of hypertension, organized in line with the World Hypertension Day 2025, in collaboration with the Non-Communicable Disease Directorate of the Ministry of Health, Sri Lanka. First, I wish to extend our sincere gratitude to our distinguished speaker, Professor Neil Poulter, for joining us today and for your brilliant and thought-provoking sessions, which have provided invaluable insights into hypertension management strategies that will no doubt enrich our daily clinical practice. Our heartfelt thanks goes to Dr. Champika Wickramasinghe, Director of Non-Communicable Disease Directorate of Ministry of Health, for your vision and supporting this event, and the Non-Communicable Disease Directorate of the Ministry of Health, not only for their endorsement, but also for facilitating the event's logistics and refreshments. I would also like to thank Professor Chamila Methananda, Chairperson of the NCD Expert Committee at Ministry of Health, for curating today's scientific program and for your seamless coordination of the event. To Dr. Krishanta Jayasekara, President, Sri Lanka College of Internal Medicine, thank you, sir, for your guidance and the unwavering support in bringing together this important platform. Our appreciation also goes to GETS, Searle, and Servier Pharma for their generous sponsorship, without which this event wouldn't have been possible. We are also grateful to Mr. Kumar Senanayaka for his support in capturing today's moments through photography. A special mention to Dr. Chanu Munasinghe for his excellent comparing and helping to keep the program engaging and well-paced. Finally, I would like to recognize and thank our dedicated SLSIM office team and staff for their tireless efforts behind the scenes in organizing and coordinating all aspects of this event. To all our physical and virtual participants, Your engagement and enthusiasm made this event successful, and let us now take the knowledge we have gained and translate it to better care for patients. Thank you all once again, and I wish you a pleasant rest of the day. Thank you.